Lithium, Pramipexole, buproprion, Carbamazepine, valproate, and Trazodone. These are our final meds that require special skill to start. Welcome to the Carlat Psychiatry podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a Psych NP and a dedicated reader of every issue. We started this series with some sound advice. Ask the patient if they'd rather go fast or slow when titrating a medication. But patients expect us to be the experts, and you need to know where the lines are drawn.
That is what the rest of this series has been about. Like, don't start above 1 milligrams with prazosin. Don't speed up on the titration of clozapine or lamotrigine, and go extra slow when drug interactions are present. I also lean toward the slow side in older and younger adults, those under age 18 or over age 65 who are medically frail. And when I'm unsure of how the medication is going to affect them, like when the patient has brain injuries or they have a developmental disorder, these are populations where meds are understudied and paradoxical reactions abound. Those are cases where I'll also go slow. Then there are a few meds where we just know that the early side effects are likely going to be a problem. And that's what this podcast episode is about, meds like lithium, pramipexole, and buproprion. At the end, we'll close with a research update on antidepressant withdrawal. First is buproprion, Wellbutrin. This antidepressant has a reputation for causing insomnia and anxiety, and I used to get a lot of callbacks about panic on it, but 15 years ago, I learned about a trick with buproprion at an APA course, and I've not had that problem since. Though the PDR suggests starting buproprion at 150 to 200 milligrams a day, I often start lower, 75 milligrams a day, in anxious patients, and I raise it very slowly, by 75 milligrams every week. I also use this strategy when starting buproprion in bipolar disorder, which is rare as I don't use antidepressants much in that illness, especially bipolar type 1. Now, I don't have proof of this, but I think antidepressants are less likely to disrupt mood in bipolar if they are titrated gradually, and also if they're tapered off gradually. Abrupt physiologic changes, from time zones to childbirth to medications, are common causes of manic switching.
I found the same strategy helpful with topiramate. I haven't seen as many cognitive problems on this anticonvulsant since I started titrating it real slow, starting at 25 milligrams at night and raising by 25 milligrams every week. I also keep the dose low, preferably around 100 milligrams. This works well because most of the psychiatric conditions that topiramate treats, like binge eating and obesity, are not emergencies, so you have time to raise it gently.
Carbamazepine is another one where slower is often better. That's a secret the late Fred Goodwin shared with me. He had seen how the slow titration that lamotrigine required made that anticonvulsant not just safer, but also better tolerated. So he started titrating carbamazepine slowly as well, starting at 100 milligrams a day and raising by 100 milligrams every 5 to 7 days. That led to a lot less dizziness and sedation. But if your patient is in acute mania, you might need to raise it faster. Carbamazepine is also one that induces its own metabolism, so you should expect the levels to drop after about 2 to 3 months on the drug, at which point you're going to need to raise the dose. And if you read the protocols on how to do this with carbamazepine, it can sound quite intimidating, like you have to get the serum level checked after steady state, and again 2 months later, all at the exact time. Well, imagine getting a manic patient to adhere to these exact times or even to check their labs. But in reality, don't sweat it. Remember that serum levels of carbamazepine were developed for epilepsy, not bipolar. so you don't need to be exact here like you do with lithium. We don't actually know what the ideal serum level is for carbamazepine in bipolar. If you use carbamazepine, you're basically going to dose it by the patient's response. The serum level is only a rough guide. I also start lithium slow. Again, the luxury of outpatient work. When I start lithium, my goal is usually long-term prevention, so I'll start it as slow as the patient needs to. Slower if they are afraid of lithium, like 150 at night until they are comfortable with it, or even lower, sometimes using the liquid form if they've had bad experiences with lithium in the past. Pramipexole is another one that I start low. In depression, I'll start at 0.125 to 0.25 milligrams at night, and I'll raise by the same amount every 5 to 7 days. With Pramipexole, once you get to 0.75 milligrams, you can raise it faster, but going too fast with this one causes a lot of nausea and fatigue, and sometimes orthostatic falls. There are also meds where the dosing in the PDR is way too aggressive for everyday practice. We went over that with antipsychotics, and we'll cover a few more here. Take valproate, Depakote ER. The dose in the PDR is actually the loading dose, something we use for acute mania on the inpatient unit where you give 10 times their weight in pounds or 25 times their weight in kilograms, but I like the pounds formula. But on the outpatient side, the bigger risk with valproate or any med for mania is the patient is going to stop the medication, so I don't use loading dose much on the outpatient side. Instead, I start valproate Depakote at 250 to 500 milligrams at night and raise the dose gradually.
We mentioned this problem earlier in the series with antipsychotics. Their PDR dosing is also based on hospitalized patients for psychosis and mania. I do not start aripiprazole at 10 to 15 milligrams a day like the PDR recommends. I start at 2 to 5 milligrams to prevent akathisia. But even with depression, the PDR can edge too high with antipsychotics. They recommend dosing lumateperone, Caplyta, at the same dose as the treating dose. Start at 42 milligrams and keep it there in both bipolar depression and schizophrenia. When it first came out, that was the only size available. But a lot of us had trouble with that strategy, and that's probably why they now make lumateperone in 10.5 and 21 milligram doses, which is where I like to start it.
Trazodone is another one to raise slowly, at least when you're using it for depression. Is anyone out there using Trazodone for depression? Well, why not? It deepens sleep quality, it has little to no weight gain, and little sexual side effects. It's supported by a lot of research in all kinds of depression, from severe inpatient cases to mild outpatient ones. And Trazodone has a unique mechanism, so it might increase the odds of success over switching from, say, sertraline to duloxetine. People give out Trazodone left and right for insomnia, but I rarely see it used in depression, and that's probably because it causes too much fatigue. Not so if you give it all at night, and unless your patient has low blood pressure on it, most people can tolerate Trazodone all at night in the antidepressant dose range of 150 to 300. But if you do start using Trazodone, you're gonna need to know this secret of titration. Trazodone is not just better tolerated, but also more effective when it is titrated slowly. The reason is that Trazodone produces a nasty metabolite called MCPP, and when MCPP levels spike, it can cause dysphoria, anxiety, even suicidality. When Trazodone is raised slowly, its metabolite also moves up slowly, resulting in better outcomes for your patients. Start Trazodone at the lowest dose, 50 milligrams at night, and raise it by 50 milligrams every 5 to 7 days. When you get to 150 milligrams, let it rest for a few weeks and see if it works. If not, you can raise it slowly again. The dose range for depression is 150 to 300 milligrams for Trazodone.
Here are some psychopharm curiosities. Medications where the starting dose is the same as the treating dose. Those are desvenlafaxine, Pristiq, start at 50 milligrams, and most of the time you stay at 50 milligrams. Paliperidone, Invega. This antipsychotic was originally released and is only available as an ER form. That improves its tolerability, so it can be started at the treating dose, 6 milligrams a day, though you can go higher to 12 milligrams if needed. When I start these medications, I remind them that this feature is an advantage. Starting at the treating dose helps them get better faster, at least in theory.
We could also add the opioid blocker naltrexone here. It only comes at 50 milligrams, which is also the treating dose, but naltrexone can cause nausea, so I usually ask the patient to cut that pill in half and take it with food as they start it out. I'm usually prescribing naltrexone in alcohol use disorder, where motivation to change and med adherence are not always high. Another one where you tend to start at the treating dose is ondansetron, used off-label for OCD. This one is very well tolerated. There's a couple controlled trials supporting it, and you start it at 4 milligrams a day for OCD. All of those trials with ondansetron were done as augmentation.
Let's end with the most unusual dosing schedule in psychopharmacology. There's one medication that you need to start at a high dose and then lower down. Can you guess it? Disulfiram, Antabuse, for alcohol use disorder. The point of this one is to block the enzyme that gets rid of the hangover-inducing alcohol byproduct as the aldehyde. So you start disulfiram high, 500 milligrams per day for a week to quickly block the enzyme, then lower down to 250 milligrams for the long term.
But do we have time for a research update?
Yes. It is Incidence and Nature of Antidepressant Discontinuation Symptoms, a systematic review and meta-analysis by Mikhail Kalfas and colleagues from JAMA Psychiatry.
Antidepressant withdrawal is a big deal. There are patient advocacy groups devoted to it. A few years ago, the New York Times investigation into it went viral. But the research world has been unfazed by it, and this study furthers the divide between how researchers and patients view this syndrome. The authors analyzed 18 randomized controlled trials that assessed discontinuation symptoms with a standardized rating scale. Compared to placebo, abrupt cessation of antidepressants did lead to withdrawal symptoms, but the effect size was small, equivalent to a single extra item on the withdrawal rating scale.
I'm almost relieved. But turning back to the New York Times story, I have to contend with Victoria, who tried to stop sertraline after 3 years on the medicine. Basically, that's all I've been doing, dealing with the dizziness, the confusion, the fatigue, all the symptoms of withdrawal.
That is the first problem with this analysis. They measured withdrawal by number of symptoms, not by severity. Many patients only report a single symptom like dizziness or brain zaps, but it can be quite severe. I had one patient with bipolar disorder who developed brain zaps after stopping fluoxetine. For 2 years, that was his chief complaint, the brain zaps. Even as he went through mania and mixed states, it was the brain zaps that bothered him most. The other problem with the analysis is that the studies were short-term. On average, the patients only took antidepressants for about 5 months. It's very rare to see problematic withdrawal at that kind of duration. In contrast, the New York Times estimates that in 2018, 7% of Americans have taken antidepressants for at least 5 years. 11% have been on them for at least 2 years. So forget about the population of depression. Here, we're saying that 1 in 10 Americans would actually not meet the criteria of 6 months duration in this study.
Yes, in 2015, researchers looked at antidepressant withdrawal in 180 patients who had been on the antidepressant for 3 to 15 years. 74% of them had withdrawal symptoms.
Withdrawal symptoms are more common with short-acting drugs like venlafaxine and paroxetine, but out of the 18 trials in this analysis, only one of those trials involved paroxetine and none involved venlafaxine. 40% involved meds that have few withdrawal risks, like the long half-life vortioxetine or the European antidepressant agomelatine, a melatonergic drug that has virtually no withdrawal symptoms at all. These papers also use standard research-based doses of antidepressants, but withdrawal problems tend to be more common when patients take higher doses for prolonged periods, as often happens in practice, even though it shouldn't. With the exception of tricyclics, antidepressants generally don't have a dose-dependent benefit beyond the medium to low range, which is like 20 to 40 milligrams of fluoxetine. But you know what happens in practice. The longer you stay on the drug, the more depressed episodes you tend to have. I mean, I'm not saying that antidepressants cause that, but just as people stay on a long time, they're going to have times of depression. And psychiatrists are going to raise the dose up, even though we don't have evidence that works. And this means that people who've been on the antidepressant a long time tend to be on higher than necessary doses, leading to more withdrawal problems.
The bottom line, this trial is well designed within a limited range. And within that limited range, it reassures us that antidepressant withdrawal is not a big deal if you've been on them for less than 6 months. But if your patient has taken them for longer, or used a high dose or a short-acting med, abrupt cessation might cause some trouble. Join the conversation on this and other papers on LinkedIn, Twitter, Facebook, and Blue Sky. Search for Chris Aiken, MD. Do you have any tips on starting psych meds? Send them to caiken@thecarlatreport.com. You'll find more dosing secrets in our textbook, Prescribing Psychotropics, the book that Nasir Gami calls not only useful, but engaging and entertaining.